Hello everyone, welcome to Professor Orthodontics, your online classroom to understand orthodontics in simpler terms. Today's class is a continuation of the previous class, which was on retention and relapse. So this class will focus on pericision. Pericision is a periodontal surgical procedure which is carried out at the end of orthodontic treatment to decrease relapse. So pericision, it is just an adjunct to increasing retention after orthodontic treatment. Only pericision will not be adequate in improving retention after orthodontic treatment. So let's begin. Another term for pericision is CSF, that is Circumferential Supracrestal Fibrotomy. The term CSF or Circumferential Supracrestal Fibrotomy was coined by Campbell. To understand what CSF is, we can break it down into three parts. It is basically a surgical procedure where periodontal fibers, are incised, hence the term fibrotomy. Where exactly are these fibers located? They are located above the dentoalveolar crest, hence the term supracrestal. And what is the pattern of this incision? From where to where does it extend? It extends all the way from the labial surface of the tooth going behind the tooth along the lingual or the palatal surface. By doing this, you are circumferentially incising all around the tooth, hence the term circumferential. This is a repeat slide from our earlier class on retention and relapse. You remember when we discussed this slide, we discussed basically why is the minimum retention period for any orthodontic treatment is 8 to 12 months. That is, at least 1 year of retention is required. So just to repeat the important points of this diagram, the reason why 1 year retention at least is required is that the alveolar bone takes almost 1 month to completely calcify after fixed appliance is removed, because we know that during tooth movement there is cyclic bone deposition and bone resorption. So for the bone to completely calcify after orthodontic treatment, at least 1 month will be required. Then after that, the periodontal ligament fibers usually take 3 to 4 months to completely remodel and readjust on the cementum surface of the tooth. The gingival collagen fibers take 4 to 6 months and the circumferential supracrestal fibers take around 8 to 12 months. Now today the focus of the class will be on these fibers, which take at least 8 to 12 months. Rathicek conducted various studies and he histologically divided gingival fibers and periodontal fibers. Now, according to him, there are 10 different kind of gingival fibers. Now, from here in the diagram, you can clearly see the fibers running from this dental cementum all the way to the gingiva are dentogingival fibers. Similarly, those running from the dental cementum to the periosteum of the alveolar bone is dentoperiosteal fibers, and so on. Of these, the fibers that are located over here below the junction epithelium are your circumferential supracrestal fibers, and the fibers that run between two proximal surfaces of adjacent teeth. For example, over here you've got, for example, maybe one mandibular center incisor and another mandibular center incisor in cross section. So the fibers which are running from one cementum surface to another cemental surface in this interproximal area are called the transeptal fibers. Pericision mainly concerns with these two fibers, the incision of these two fibers. Now, where exactly are these circumferential supracrestal fibers located? This is closely related to the junction epithelium. The junction epithelium histologically ideally should lie on the enamel, and it should lie, if this is the enamel of the tooth and this is the cementum, it should lie above the CEJ, that is the cemento-enamel junction, and it should lie completely on the enamel. That is the definition of a ideal or a healthy junctional epithelium. It is apical to this base of junction epithelium that you find the circumferential supracrystal fibers. It is said that these fibers run haywire in all possible directions. That is, these fibers are divided into three types: apical, coronal, horizontal. So they are running north, south, and in every direction. They form a strong meshwork. It is also due to these fibers that the strength and resilience of the gingiva around the tooth is increased. These fibers give additional resilience to the gingiva, hence preventing recession of the gingiva. So it's not like these fibers are all bad. They have their own important function. So these are the fibers that are also contributing to the strength of the gingiva and preventing it from recession under ordinary forces, regular forces such as your masticatory forces, or even minor traumas here and there. Brighton conducted histologic studies in dogs, and he found that during orthodontic treatment, these fibers particularly become taut. They remain stretched and twisted. Those were his words. They remained stretched and twisted during the orthodontic treatment, and most of the fibers took almost 232 days to readjust to the new position of the tooth. That's a long time. So it's not like the first CSF procedure is the one that we are studying right now. There were CSF procedures or attempted CSF-like procedures even before. So the first ever Pericision or CSF-like procedure was called as Asceptotomy, and it was carried out by Skogsberg. The advantage of this procedure was, of course, the rotational relapse was lesser. Disadvantage was the procedure was quite aggressive and invasive. In this procedure, a vertical cut was placed on the interdental interseptal bone, hence the word septotomy. So the septal bone was vertically cut. So by doing this, the fibers which are integrated into the cortex of the bone was removed. This was done with the help of burrs, not with the help of any incision. Now the problem with this is that it is an aggressive procedure, and it was so invasive that it resulted in gingival recession and hence resulted in unesthetic black triangle zones that happens due to gingival recession. When interdental papilla recesses, you end up with black triangular empty zones, also called as back triangles. So this was a disadvantage of the first surgical CSF-like procedure that was given. The CSF procedure that we usually follow today are closely based on Edwards' technique of Pericision. What Edward did was he used a Bart-Parker blade, number 11 Bart-Parker blade, placed incision such that the bell was directed towards the alveolar crest, and this incision was a circular type of incision going all the way from the labial to the lingual surface of the tooth, which we do even today. But the incision was placed quite apically. It was at least 2 to 3 mm beyond the alveolar crest. Hence, by doing this, he ensured that all the crisscrossing supracrystal fibers and the transeptal fibers were cut with the help of this procedure. He observed that after the procedure, immediately the tooth had some transient temporary mobility, which healed over time. So it took a period of 3 months to heal the tooth completely. Although the procedure was successful, rotational relapse observed was lesser in these teeth. He also realized that to some extent there was a risk of gingival recession. And he also advocated that it is better to avoid doing this procedure in those individuals where the gingiva is not in a healthy condition, particularly those wherein the cortical bone was thin, attached gingiva was narrow, and these are the cases wherein it is not advocated to carry out CSF procedures. Edward carried out long-term studies. He conducted long-term follow-up studies and he observed patients who have undergone CSF procedure and compared them with those individuals who have not undergone CSF procedure. So those individuals after orthodontic treatment who have undergone CSF procedure were observed after 4 to 6 years and 12 to 16 years. Sorry, it is 4 to 6 and 12 to 14 years. He observed that both the groups of people, whether observed after 4 to 6 years or after a few more years, that is 12 to 14 years, showed lesser chance of rotational relapse when compared to those individuals who only underwent orthodontic treatment and retention and without any CSF procedure showed higher chance of rotational relapse. So the advantage of his study, good findings of his study was that yes, rotational relapse is lesser. Yes, it is more beneficial in maxilla than in mandible. Yes, more in the anteriors than in posteriors. Problems were that to some extent relapse was still present in some teeth because it is difficult to clinically predict to which extent are you incising these fibers when you do the procedure. We have to understand that practically it is not possible to imagine where these fibers are located. Each and every fiber is running in its own direction and the Bart-Parker blade is too large to fit into the small periodontal ligament apparatus that is present in the dentition. Now, another problem with this procedure was that it was technique sensitive. There was still a chance of gingival recession. Van der Linden modified this technique further and he said that we can avoid gingival recession completely by completely avoiding sulcular invasion. So instead of placing circular incision, he suggested you place the incision through the marginal gingiva. So by doing this, you are avoiding touching the interdental papilla, you are avoiding touching the gingival sulcus, and hence you are basically avoiding gingival recession. This was his concept. So his idea was do the same procedure but through the marginal gingiva. So by doing this, you are avoiding those areas which can lead to gingival recession. But the problem was that, yes, once again, the blade was directed towards the alveolar crest, but then slight shift in the angulation can result in either your hands, your blade, slipping away from the direction of motion to the attached gingiva. So you may actually damage the attached gingiva. And if you slightly increase the angle by accident, then you may go too obtuse and you may end up entering the periodontal apparatus instead. So in both the ways, you're either removing the inner enamel epithelium or you're damaging the attached gingiva. Hence, it is a technique sensitive procedure. The main advantage of this procedure was that there was lesser chance of anesthetic black triangles that happens due to gingival recession. The interdental papilla was safer. And yes, to some extent rotational relapse was decreased. But then again, because the access to the area was lesser in this procedure when compared to Edwards' technique, the chance of relapse was little higher. So these were the three techniques rather, which were different types of pericisions. The ones that we are following today or these days are mainly based on Edwards' technique of pericision. So, finally coming to what exactly is CSF. CSF is also called as Circumferential Supracrestal Fibrotomy, also called as Pericision, which involves placing vertical incisions all around the tooth, which incises the supracrystal gingival fibers. The procedure is done in an outpatient department. Patient need not get admitted for this procedure, and it is not a major surgery, it is a minor surgery. Hence, it is done under local anesthesia. Because only a minor incision is placed, periodontal dressing is not required. The incision is placed such that at least one tooth mesial and one tooth distal to the tooth is also involved. That is, say you want to perform CSF procedure for maxillary right canine, then the maxillary right first premolar and the maxillary right lateral incisor should also be incorporated into the procedure. The teeth that can benefit from this procedure are somewhere ranging from 10 degree onwards. So say a tooth is rotated more than 10 degree, severely rotated teeth, and you have treated them orthodontically and corrected it. To decrease the chance of relapse, CSF can be performed. 30 degree is just a range, but starting from 10 to 30 degree, CSF procedure can be performed to decrease the chance of rotational relapse. So what's the aim of this procedure? Aim of CSF procedure is to decrease the rotational relapse. So Edwards' long-term study proved that the advantage of CSF or benefit of decreased rotational relapse was more in maxilla than in mandible. He also found that it was more beneficial in anterior region than the posterior region. And this relapse was more beneficial for the rotational corrections and not for labiolingual corrections. So say a tooth was excessively proclined before treatment, and after treatment the inclination was corrected, and you perform a CSF procedure to decrease its relapse to its proclined pre-treatment position. It may not be very helpful. So it's beneficial only in the mesiodistal plane and not in the labiolingual plane. And when do you perform CSF? CSF is performed usually at the end of orthodontic treatment. There are three main stages of orthodontic treatment with fixed appliance. First is initial alignment and leveling. Second is space closure. Third is finishing and detailing. Finishing and detailing is the final stage of fixed orthodontic treatment, and it basically involves fine, minute corrections, maybe a few fine wire bendings, fine occlusal settlings, and all that. During this procedure, only settling of occlusion and fine settling of the roots, etc. is carried out. So it is during either the end of this stage or completion of this stage that CSF should be performed. According to Edward, no active orthodontic tooth movement should be being carried out while CSF is performed. So all active orthodontic movements should be complete when you perform CSF. There is some controversy regarding when exactly it is to be performed. There are researchers who promote carrying out CSF during the end of orthodontic treatment, that is at the end of the finishing and detailing stage of fixed appliance treatment. And then there are those who say it should be done after debonding. Now we will learn the pros and cons of both. Edwards suggested that it should be done at the end of orthodontic treatment, wherein no orthodontic active movement has to be done or is being done. Now the reason being, immediately after Pericision or CSF, the tooth is mobile to some extent, and it needs at least 3 months to completely heal and readjust to the new orthodontically corrected tooth. That is, the fibers have to beautifully bond with the readjusted tooth, orthodontically corrected tooth position. And immediately after CSF procedure, some amount of temporary tooth mobility is also seen. So these are the reasons why it should be done at the end of orthodontic treatment and not after debonding. Now there are some advocates that say that it should be done after debonding. First reason is that due to the presence of brackets on the labial surfaces of teeth, it is difficult to angulate the Barth-Parker blade towards the alveolar crest. it may be difficult to handle and angulate the plate and perform the surgery. So the access to the surgical site is reduced. So you may make errors in angulation of the blade. So this is one disadvantage. Another disadvantage of having the brackets on is that some individuals fail to maintain good oral hygiene during orthodontic treatment and end up with slightly swollen gingiva, which is simply a sign of gingivitis. Gingivitis would simply indicate that these individuals will also have poor healing. How can you perform any periodontal surgery in the presence of gingivitis? It will definitely result in gingival recession. So those individuals with poor oral hygiene and hence gingivitis should not undergo pericision until either the gingivitis is treated, that is, the patient improves oral hygiene and follows other instructions, etc., or after the debonding and after the gingivitis has corrected completely. So Roth also conducted another study, and he studied the trabecular and the cortical bone. He found that those individuals wherein the cortical plate of the mandible was thinner showed higher tendency for relapse when compared to those where the cortical plate was thicker. To summarize this lecture, I would like to talk about the contribution by both. So Roth also conducted a study, and he found that mandibular incisors, yes, mandibular incisors do show a lot of relapse, but he found in his study that those individuals who have undergone a good retention period following orthodontic treatment, circumferential supracrestal fibrotomy, interproximal stripping, overcorrection of orthodontic corrections, and selective root torquing of the mandibular incisors have shown overall lesser relapse when compared to those who have not. So he advocated use of combination of two or more of these adjunctive procedures such as interproximal stripping or circumferential supracrestal fibrotomy than just relying only on the retainer. But then again, there is not a lot of scientific evidence to suggest that all of them have to be done to improve retention, and there is no proof that performing all these procedures together will give you 100% retention. So I would like to conclude this lecture with the fact that orthodontic retention is an ongoing orthodontic active treatment. So removal of fixed appliance is not the end of orthodontic treatment. It is very important to educate the patient that he or she plays an equal and important role in maintaining the orthodontic correction by following the instructions and wearing the retainer. The longer the patient wears the orthodontic retainer, the longer will he benefit from the treatment of the orthodontic correction. That's it, guys. Thank you for listening. If you are interested in learning more about orthodontics, subscribe to my channel. If you like this episode, do like the button. Do click on the like button. And if you have any suggestions or any queries, please drop them in the comments below. Happy learning.